month, 15 to 115. Today is Depression Update, Rollout of new MCPAP Depression Algorithm. Housekeeping issues. We do record sessions and they're available on the MCPAP website at www.mcpap.org. We also will post a copy of the PowerPoint slides on Archive News and Webinar page about MCPAP on the website. If you have questions or comments, please type them into the question box on the lower right hand of your screen, and we'll either read your question or we may be able to unmute your line to enable you to ask the question. We will try and hold most questions to the end of the session unless it seems to be something that needs clarification along the way. There will be a brief survey following the presentation. We appreciate your feedback to help us improve future presentations. Now, to introduce Barry Servette, Medical Director for MCPAP, who will introduce today's speaker. Barry?
John. Hi, everybody. It's a pleasure for me to introduce our speaker, Bruce Waslick. Bruce is a child mental psychiatrist. He is the Chief of Psychiatry at Baystate Health and UMass Baystate. And he is the Medical Director of our Western Central team. Many of you know, and he's been a leader within MCPAP since the very, very beginning in 2004. Bruce he received his medical degree at Tufts University, and he did his psychiatric residency training at Tufts, and then he went on to Columbia for his child psychiatry training. Bruce is an expert in many things, but especially in the treatment of adolescent depression, and he is a clinical trials research scientist, and actually Bruce was the site principal investigator for the NIH-funded PAD study, which was a landmark study of treatment of adolescent depression, which really informed practice in the field for many years and actually to this day. So I think Bruce is well qualified to talk to us about adolescent depression treatment. I do want to say that we're really excited about today's clinical conversation because this is the very first of a series of reductions of clinical practice guidelines, which is a new thing that we're doing. And we're really excited about it because we're looking forward to really having these practice guidelines be directed outwardly towards the pediatric community in Massachusetts in order to reduce variation in practice towards the adoption of really best practices and evidence-based practices in the common areas of children's mental health. And we're also actually really excited about the opportunity to use these guidelines kind of internally in order to reduce some of the variation in practice among our MCPAP consultants and really have it be a synergistic process where the MCPAP consultants throughout the state are giving phone consultation in keeping with and really in alignment with these guidelines and then promoting kind of the actual expression of practice with these guidelines in the community. And so we're pleased this is our first one, and so I think at this point I'll turn it right over to Bruce and we'll get right in.
Well, thank you, John, and thank you, Barry, for that nice introduction. And I'm going to just give a slide here about what we hope to do today. So the first is basically to introduce the conceptualization of the MCPAP clinical algorithms. introduce that just in what he's saying, but I'll talk a little bit more in detail. And then the bulk of the presentation is going to be on the new PAP depression clinical algorithm. And go through it in detail, and we'll be very interested in hearing any questions or comments at the end. So I'm going to hopefully leave enough time for people to weigh in with questions or comments. Here is really the purpose of the MCPAP clinical algorithm. So we got together as a group, and we were hoping to create a group of practical clinical guidelines for primary care providers when they are dealing with common mental health problems. And I'll talk about the ones we've taken on first, an overview and a preview of what's coming. Our goal was really to be practical and clinical for primary care. And the idea would be to give primary care providers a set of screening procedure recommendations to talk about the process of going to the evaluation, really more of a diagnostic evaluation, to know that we've got the right diagnosis when we're proceeding through the guideline. A little bit of a look at treatment planning considerations in terms of what are the typical types of recommendations we're making for kids and families if we have an accurate diagnosis. And then also to primary care providers to give some medication treatment guidelines, especially for first-line treatments when you're dealing with a relatively new problem. As we'll talk about further down, the guides are not going to be able to sort of encompass the multiple treatment refractory or highly complex patients. That's not really the purpose of the guidelines. But we want to give some first-pass medication treatment guidelines so that people will have an idea about what to do with cases they diagnose in primary care moving forward for the ones that are appropriate for medication treatment. Just a word about the content in general. The content is really developed to be most helpful for the primary care provider and regular primary care practice. These are not specialty guidelines. These are really for primary care. Content is meant to include procedures that can be performed in all the algorithms in the context of regular primary care practice. So they're not specialized for different settings. They really are meant to be useful to people working in the context of their regular primary care practice. They're not going to be able to implement all the components of the treatment in primary care, but at least the focus on what you can do as a primary care provider and a comprehensive treatment plan will look like for these cases. The content is you'll see, and you'll see this in the depression guidelines, the content is recommending the use of standardized, well-validated clinical rating scales that can be used in primary care practice. And for the most part, we'll be talking about rating scales and clinical supplements that are in the regular domain, so that they're not copyrighted and going to cost the practice a lot of money to be able to implement. And also the content is recommending the use of medication guidelines suggesting evidence-supported first medication treatments for mental health conditions commonly treated in primary care. We'll also be taking into account FDA guidelines to some extent, but we're all aware the FDA guidelines don't comprehensively cover the use of medications for children with psychiatric problems in all cases. So that we will make use of FDA guidelines when they're available, but obviously we're not going to be able to do that for all cases for all medications. Just a little bit about the process of the development of the clinical guidelines and the clinical algorithms. Content was really developed through a clinical consensus process utilizing the various members of the medical director's leadership team. We've come together and we've processed the guidelines that we really want to discuss. And starting with this depression guideline, this is a product of the clinical consensus process from our leadership team. The initial guidelines for different conditions are based on some work by Heather Walter and her colleagues at Boston Children's. They're a learning collaborative for the PPOC practices. So you will see some similarities if you're from a PPOC practice between some of the guidelines developed by Heather and her colleagues and the MCPAP. So we use that as kind of a starting point for a couple of guidelines, but the guidelines were further developed using the medical director leadership team. And the first three guidelines that we're going to be talking about and presenting will be today's presentation on depression. We can also look forward to the near future when we'll have an anxiety guideline, clinical algorithm out, and also an ADHD clinical algorithm. So those will be coming in the near future. Again, here are the applications for the clinical algorithms to really help train primary care providers in basic evidence-supported tools and procedures for mild to moderate, relatively uncomplicated forms of mental health problems that can be reasonably handled in primary care practice. And it's also, as Barry mentioned, it's really to help the MCPAP consulting teams provide consistent training and guidance to primary care providers, doing both phone and face-to-face consultations across the state. So that we should reasonably be able to expect that if a kid presents with depression in Massachusetts or Western Massachusetts, they'll hopefully get exposed to the same clinical algorithm at the primary care level, at different locations in the state. So it really is meant to try to enhance consistency and reduce variability of evidence-based practice throughout the state. Obviously, individual circumstances always have to be taken into consideration when people are making actual treatment decisions one-to-one. We're hoping that the clinical algorithms will help reduce variability and increase consistency across the state. I think this is true, that the algorithms are likely not going to be the best starting point for severely ill, treatment-resistant, or highly complicated presentations of mental illness in primary care. That's really not the aim of the clinical algorithms at this point in time. It really is meant targeting relatively simple, mild to moderate cases, and for cases that are really more severe and they don't necessarily fit into the guideline because they're treatment-resistant or they're really severely ill or very highly complicated with either medical or psychiatric or psychosocial comorbidities, co-occurring problems. We're really encouraging people to make liberal use of the MCPAP phone consultation and face-to-face consultations for these cases, which are much more complex and outside the scope of the basic clinical algorithms. Okay, so it's really now I wanted to spend most of the rest of the time just talking about the MCPAP depression clinical algorithm. Like we said, this is the first clinical algorithm that we're rolling out for the MCPAP teams. We're rolling them out for primary care providers across the state, and we're also rolling them out for our internal MCPAP teams across the state. And the MCPAP depression clinical algorithm is going to provide clinical guidance for the primary care provider in terms of screening for depressive illness in children and teens. Also, some procedures for doing a diagnostic evaluation. Make sure that when we move on to treatment planning, we are confident that we've got the right diagnosis and we're in the right clinical algorithm. We'll talk about some treatment planning considerations and looking comprehensive at what a comprehensive treatment plan will look like. Also, because primary care providers are called upon to do medication treatment for selected mental health problems and psychiatric disorders, we also devoted some rather specific information about initial medication selection and management procedures. We are not expecting that in each primary care practice we're going to have people trained to provide psychotherapy and things like that. If your practice does have trained psychotherapists working in the clinic or closely affiliated with the clinic, that's great. But we're not assuming that. But we are assuming that at least in some situations, a lot of primary care providers are going to be asked to involve with the medication treatment. So we've given some extra attention to the medication selection and management procedures. And I don't want to get too hung up on this. This is what it's going to look like. This is the overview with a flow And I'll highlight some areas, and then we're going to go into each area more specifically. The first thing I wanted to highlight was at the bottom there is an acknowledgement to Heather Walter and their colleagues at Boston Children's. Talks a little bit about the origins and the process of development. The content of the guideline of the algorithm is really in the other areas. So up top we have screening and evaluation procedures, which we will cover in a few minutes. We're going to talk a little bit about clinical decision-making procedures, which flow through the algorithm. We have some enhanced information on medication selection support with specific medications identified and recommended starting doses and therapeutic doses for the treatment of depression. And we also have some consolidated procedures for follow-up and monitoring support. This is what the general algorithm is going to look like, and we'll talk about each section of these in more detail at this point. Here's the acknowledgement in the origins and process. Heather Walter, thank you for your initial efforts in this area that we've adapted with the leadership team. Here are some of the screening and evaluation procedures. So you can probably conceptualize that you might be referred a case of depression in two possible ways, probably more than two, but I can think of two. One is that you go through a screening procedure at a well child visit or a health maintenance visit, and the child might screen positive for a mental health screen indicating some symptoms of depression. Alternatively, a child or family may seek an evaluation or a treatment visit specifically because of concerns about mental health problems. So, from the screening point, if everybody is screening mental health problems, you'll probably be administering a screening form. We'll talk about the forms that we're recommending for screening for depression in a few minutes. But so you'll end up with a screen for a behavioral health problem, and there are basically sort of two ways to screen. One is to sort of do a general screen looking at all or many different types of mental health problems, mood disorders, anxiety disorders, ADHD, behavioral disorders, and that usually uses a more general screen instrument such as the pediatric symptom checklist, which I know out of practices, at least in Western Mass and Central Mass, are using as their mental health screener at well child visits. Alternatively, you could conceivably in your practice be using either in conjunction with the PC or as a separate screener for depression, something much more specific to depression, such as the Pediatric Health Questionnaire, the PHQ, PHQ-2 or the PHQ-9 or the PHQ-A. All those are reasonable screeners for depression using the clinical algorithm. And then once we do sort of initial screening or evaluation, we move into levels of evaluation, and also some treatment recommendations. So if we identify somebody who is presenting with either subclinical depression or even mild depression, you might recommend something along the lines of guided management or follow-up with the pediatric provider, primary care provider, just to see if the symptoms really severe and continue, or whether they're more transiently related to a specific problem. If there's concern for clinical depression, then we are recommending that the primary care provider do a focused assessment, look at things like precipitating factors, symptom rating scales, family history of mood disorder, and also red flags, which would indicate a severe problem or something which might medication use more complex or more complicated. So we do the screen, and then we want to encourage a focused assessment, to be able to have a real idea of what the underlying diagnosis is. If concerned about imminent danger based on either the screening or the focused assessment, Obviously, those kids are probably not going to enter a guideline. They're going to be referred to either a hospital or to a crisis team for emergency psychiatric assessment, especially when there's danger or things like psychosis associated with depression. So they are not going to necessarily be appropriate to follow the standard clinical algorithm. They're going to need much sooner referral to specialized mental health care. And if any of this is confusing after the screening or after the initial evaluation or after an assessment and there's concerns about danger, primary care providers are really suggested to consult with the MCPAP CPs on call as needed to help push people in the right direction to provide the best care for the individual situation. So here's an example of the PSC-17, which I think a lot of practices are probably using as a general screener, and the ways to sort of score it. We're looking at sort of the internalizing symptoms here. Item number 2, feels sad and unhappy. Item number 6, feels hopeless. Number 9 is down on him or herself. Number 11 seems to be having less fun. Or 15, worries a lot, which is more associated with anxiety. And that those 5 items are going to give you a subscale in the internalizing domain and setting as a screen cutoff of greater than, equal, or 5 on the internalizing subscale. Obviously, this is a scale that covers other things such as ADHD symptoms and also other externalizing behavioral problems. Those are not the focus of this particular presentation, but obviously you would, as a care provider, want to know all the information provided by this scale. But for the purposes of this guideline, we're going to focus on the C17I subscale being greater than or equal to 5 as being indicating of a positive screening score. Q9, this is, again, I know that some practices are using the PHQ9, and this is basically a list of depressive symptoms. This particular form has shaded areas and anything registering on the 2 to 3 range, which would indicate clinically significant items. And this is about the last 2 weeks. How often have you been bothered by any of these problems? Item number 9 is a screener for suicidality, and at the suicidal level, we're going to consider something deserving further attention. Anything scoring 1, 2, or 3, meaning several days, more than half days, or nearly every other day. It has a 10th question, which is how much are these symptoms affecting you? How bad does it make you feel? How difficult does it make you to be able to function in different areas of your life? Enter that as not difficult at all, somewhat difficult, very difficult, or extremely difficult. And now when we talk about psychiatric disorders, it's not just a symptom complex, it's also a symptom complex in association with some degree of suffering or some degree of functional impairment. Okay, if we use this as a screening, we're going to consider MDD positive if there's 5 checks in the shaded boxes, with question 1 or 2 positive. Other depressive disorders might be if 4 boxes are checked off with question 1 or question 2 positive. This does come with a score scale, which gives you an idea about what level of depression you're at based on the total summary score. So 1 to 4 is minimal depression, 5 to 9 mild depression, 10 to 14 we usually set a cutoff of 10 or higher, being indicative of moderate depression, and then gradations of more severe depression. When we get to 20 or 27, we're talking about severe depression. We are recommending that all the responses should be verified by a clinician, and as part of the evaluation, that a definitive diagnosis is made on clinical grounds. The diagnosis of major depression and other depressive disorders do require improvement in functioning on question 10 here. And for the purposes of a diagnostic evaluation, you do want to go through some rule-outs to make sure that the diagnosis of bipolar major depression is the correct. So we want to make sure that somebody's not just going through a course of bereavement, which is considered to be a normal reaction to an important loss or death. We also make sure that people are not meeting criteria for bipolar disorder. If they have a history of manic or hypomanic episodes, they may be presenting with depression, but the treatment may be very different for somebody with bipolar depression versus unipolar depression. Obviously, as primary care doctors, this is going to draw upon your expertise for these rule-outs. Mental disorders that might be presenting with depressive symptoms as part of its symptomatic presentation, reactions to other types of medications the child may be being prescribed, and also ruling out that the child is experiencing depressive symptoms or mood disorder symptoms as part of an illicit substance use or abuse situation. Diagnostic evaluation, once we know somebody's at risk for depression, I'm recommending getting an initial assessment of depression severity using one of two scales. The first is the Mood and Feelings Questionnaire. I have a slide on that I'll show you for ages between the 8 and 18. You can use either the parent-rated version or the youth-rated version or both. But also the PHQ-9 we are recommending for kids 12 and up. The cut point, again, of 10 meaning moderate depression and using a cut point 20 to indicate severe depression. Part of the diagnostic assessment is going to assess for red flags and diagnostic rule-outs that could be expected to affect treatment planning. So we talked about the diagnostic rule-outs, previous slide. But we are very interested in red flags. So red flags means that there's something going on here which has to be handled urgently or in a manner that might not fit in with the depression algorithm. So obviously somebody who's at risk for suicide, again, might need emergency referral. Similarly, if somebody is presenting with severe depression and psychotic symptoms as a piece of that, again, the standard estimate is not going to cover depression with psychosis. One of the things that I become more and more impressed as I do more and more child psychiatric work is how trauma affects presentations for kids. And kids with severe episodes or periods of neglect or trauma history often, require pretty specialized evaluation and pretty specialized treatment. And again, this may be a group of kids with severe trauma or severe neglect that might be best handled in more specialty care than primary care. So we consider that a relative red flag. There's a significant history of trauma, neglect, and you might wish again to consult with the MCPAP psychiatric teams or the MCPAP clinical teams prior to trying to move ahead with a treatment program. And substance abuse also is can complicate a lot of different things, including the treatment of mood disorders or depression. So that's all in the way of doing assessment and evaluation. Mood and Feelings Questionnaire, the long version, you can kind of go through it. It's a lot of questions about anxiety and depression. And again, although Adrian Engold here says there's no absolute cut point, in our algorithm, we are looking at a cut point of 27 rated by the parent or 29 rated by youth as being clinically significant. Getting a score on the Mood and Feelings Questionnaire and the Patient Health Questionnaire also serve as a baseline so that you have an idea of how severe the depressive symptoms are at baseline prior to beginning a treatment intervention. And you can repeat these instruments after periods of time to make sure that things are moving in the correct direction. And if that's true, then the kids' rating scores on these instruments should be decreasing over time as their symptoms improve. So it's a good way to monitor in addition to getting a baseline diagnostic evaluation. And again, it's just a repeat on the PHQ-9 with similar recommendations regarding collecting it at baseline, especially for adolescents. Here's the clinical decision making. So subclinical to mild depression, you could consider things like guided self-management with follow-up, dealing with problems that are occurring, helping the kids and families access supports where needed. And, we are expecting that, some of the kids in this area of subclinical mild depression, if they're actively followed, the symptoms are going to remit in and of themselves. They're going to deal with the problems. They're going to get the support they need. The families are going to make adjustments. The kids are going to deal with their current problems. but are recommending follow-up for these kids so that once they're evaluated and they're registering as symptomatic, there is some follow-up over time just to make sure that the symptoms do in fact recede. And if not, then we would start talking about more active treatment planning. So if we get to moderate depression, self-management is really unsuccessful, then we talk about active treatments. And the two main types of active treatments we're going to be talking about and recommending are referrals for therapy, individual therapy, counseling, and so to consider medication. With severe depression, diagnosed at baseline, again, we're not expecting the primary care doctors are necessarily going to be the people primarily in charge of these kind of treatment plans, but we will be talking about referring to specialty care for therapy, medication management until stable, hopefully done in a more specialized situation. And then once the kids are stable, potentially the primary care doctors taking over medication treatment. We're thinking that for care providers, then the moderate depression medication algorithms are going to be important, and also to be aware of medication algorithms for kids who are coming out of specialty care who have stabilized and improved to a significant degree. Medication selection support. So, we are talking about, we do have in depression, we have two FDA medications for depression. So we have fluoxetine for ages 8 and above, and escitalopram or Lexapro for ages 12 and above. So those are FDA-approved medications. Now, we certainly recognize that other SSRIs are often selected, sometimes as first-line or second-line medications treatment of depression. So we're not recommending to restrict all treatment of the FDA-approved medications. For example, evidence-based medication like sertraline is in use in the community. It's evidence-based, at least in terms of safety for depression, and it's used quite a bit, and it's a reasonable alternative for families, kids who are either not able to take fluoxetine or escitalopram or have a strong preference for using something as an alternative. So we are supporting the use of sertraline as an evidence-based medication, although it does not have FDA approval for depression in kids. It only has FDA approval for OCD in kids. So, and we're also talking about two procedures. One is starting a daily test dose for the first 1 to 2 weeks, which is probably subtherapeutic, and it's a cautious way of introducing the medication for the child in the initial stages of treatment. The starting daily test dose for 1 to 2 weeks, fluoxetine, 5 milligrams if they're less than 12 years of age. For kids who are 12 or older, 10 milligrams. And for escitalopram, 5 milligrams for ages 12 and above, starting dose. And for sertraline, the younger kids under the age of 12 consider a dose of 12 to 12.5 milligrams, or for kids who are 12 and older, a dose of 25 milligrams. So starting that daily test dose for 1 to 2 weeks, and if the test dose is tolerated, to get an increase. In most cases, we'll be getting to the therapeutic dose with the dose increases. So from fluoxetine, we'll get to the 10 milligram dose under the age of 12, and fluoxetine 20 milligrams for kids who are 12 and older after a week to 10 days, 1 to 2 weeks of the test dose. The usual therapeutic dose for escitalopram is 10 milligrams for kids who are 12 and older. And for sertraline, we'll get up to 25 milligrams after 1 to 2 weeks for kids who are age 12, and sertraline 50 milligrams for kids 12 and older. Now, sertraline has a much wider therapeutic dose range. For adolescents, it ranges from 50 to 200, with it's a much more narrow range for fluoxetine and escitalopram. So a little bit more liberalized use of sertraline. You can push to higher doses if you're not getting a benefit at the lower doses, as long as kids are tolerating the medication. So that's basically sort of the medication support, and the first 3 medications that we're recommending for depression. And also as part of the medication support, monitor weekly in some way for agitation, suicidality, or other side effects. That be done in person or through phone calls from the practice, just checking in with the family, making sure things are going okay. that extra level of monitoring and support comes in very both as a therapeutic and a safety tool to make sure the kids are reacting appropriately to the introduction of the medication. And if you get any indications that they're having severe agitation or suicidal intent or plan, you then treat that very seriously and potentially refer to the hospital or crisis team for emergency evaluation. Again, fortunately, these reactions are uncommon, but they're within the realm of the black box warning for SSRIs for kids with these medications. So monitoring and being aware of this on some level is important at the practice level. Again, if you run into any difficulties, make sure you make liberal use of the MCPAP Child and Adolescent Psychiatry consultation service, which is available during regular work hours between 9 and 5 Monday through Friday. Here's the monitoring support at 4 weeks. We're hoping that people will reassess the symptom severity using, again, one of those defined evaluation scales, the Mood and Feelings Questionnaire or the PHQ-9. We can get the score on these scales below the cut point. If the score is still above the cut point and impairment persists, then it's probably worth calling the MCPAP Child and Psychiatry at that point for a discussion about where to go from here. It could be adjusting the dose. It could be consultation. It could be changing medication. So it's certainly worth consulting with the MCPAP Child and Adolescent Psychiatrist on call to the phone consultation for next steps. If successful and the score gets below the point with mild to no impairment, then we're probably moving out of the acute treatment phase into the maintenance phase. And for the most part, if the child remains generally well with reduced symptoms and functioning is improving, then we're probably going to be talking about continuing medication for an additional 6 to 12 months. There's good evidence in adults and reasonable evidence in children and adolescents that continuing that treatment for a period of time, once symptoms have improved and functioning has improved, helps an important next step of preventing relapse of symptoms or recurrence of the mood episode. So I know that kids often want to get off the medication as soon as possible, and the parents want to do that, but we can give reassurance that there is evidence suggesting that if you continue with your medications for 6 to 12 months, we can help kids continue to feel better and reduce the risk of either relapse or recurrence of the situation. We want kids monitored, during this treatment period when they're in ongoing treatment, maintenance treatment. So we're recommending that bi-monthly monitoring visits for the second 4 weeks and monthly thereafter for maintenance of remission, agitation, suicidality, and making sure that the kids are tolerating the medication. If we see occurrence of severe agitation or suicidal intent or plan, then again, we're going to probably be involving hospital services or crisis teams for emergency evaluation. Again, feel free to make use of the MCPAP Child and Adolescent Psychiatrist as needed. If it is successful over the course of 6 to 12 months, and things are really going better, then we reassess the symptom severity with the MFQ, the Mood and Feelings Questionnaire, the PHQ-9. If we continue to below the cut point without impairment, they can start talking about coming off the medication, and that's a complex decision, and it usually involves a conversation between the clinician, the parent, and the child. But if things are going well, we could consider reducing the medication, monitoring the kids during this period of time, and eventually, hopefully, discontinuing the medication. Again, any questions that come up about this kind of decision-making or monitoring, feel free to make use of the MCPAP Child and Adolescent Psychiatrist as you see fit. We would expect a lot of discussion around this, and some families are totally on board with it, and others are anxious about this period of time of coming off medication. So additional support during this process and active monitoring about how kids are doing is pretty important. Again, just to review a couple of points. So you can see as we go through the algorithm in detail, we're talking about the kids with the most severe forms of illness that are highly treatment resistant, meaning they've been in different type psychotherapy and on different medications for other treatment episodes, or highly complex presentations of mental illness, so that we're not thinking that those kids are going to fit into the algorithm, and that those kids, you're going to see them in your practices. I know I get consults on phone consults and face-to-face consults on these quite a bit. But as primary care providers, you're really encouraged to make liberal use of the MCPAP phone consultation and face-to-face consultations. You may actively be involved with treating these kids, but you might want to be guided by a more specialized consultation as opposed to relying on the MCPAP clinical algorithm. What I wanted to get through, I hope this made sense for folks. I hope people can appreciate sort of where we're aiming with the clinical algorithms and the depression algorithm. Thank you for your attendance and your attention. And we've left some time for any questions or comments. So the questions and comments are invited and appreciated. Thank you.
Thank you very much. I don't see any questions at the moment. Would anyone, you type them under the question, or you can raise your hand. You'll see a little hand symbol on the lower right end, and we can unmute you, and you can say it in person. While we're waiting, maybe you could think back about a call you've gotten in the last little while about someone who's, because something is not going quite as the algorithm would hope it would.
I can think of all the different calls I've gotten. I can think of some that come along this following, so that even without the algorithm, some of the primary care doctors are certainly doing this kind of treatment in their primary care practice. They've been trained to do this, and then they evaluate somebody appropriately, and they get them going on an SSRI, and then what happens is the kids have an episode of suicidality while they're starting treatment within the first week or two. And it's one of the most difficult and challenging situations as a psychiatrist when you're treating depression and some of these symptoms worsen, or that they do an episode of suicidality during the initial stages of treatment. How is that a worsening of the underlying condition or a variation based on an acute stressor that's really affecting the underlying depression issue, and how, is it a reaction to the medication? That's akin to what has been reported in the black box. And that's a very complicated clinical situation that I know primary care providers are dealing with. There's no easy way to sort that out. I think one of the things that happens is that the primary care doctors often will contact the consultants, walk through it, and we'll usually ask questions like, were the kids suicidal before you started medication? Are they suicidal in a different way, meaning they had vague suicidality and now they've got an acute plan, or they're really feeling like they're going to carry through with it, or whether anybody's noticed any unusual mental status changes, such as increasing in agitation or irritability, which again could indicate a negative reaction to the medication. Again, the treatment guideline sets up the algorithm sets up the start of treatment, but these subtle decision-making processes along the way are complex, and I think getting that support with that kind of situation or other situations from the MCPAP CAPs on all are completely appropriate uses of implementing the algorithm, but also making little use of the psychiatry support available as well.
Thank you. So now we have some questions. So first of all, just a visual one, question about whether this algorithm will be available on our website. It'll be probably within the next week or so. So don't go in there this afternoon, but we hope to have it in there up next week. So one of the questions that came in was, what about depression treatment in a patient who already has ADHD?
Okay, that's, again, that's one of those situations that's complex. I think that you will find, and I find this as a psychiatrist, you're going to be able to utilize the MCPAP clinical algorithm for certain situations where you do have some level of complexity. So we see certainly a fair number of kids who have ADHD. The ADHD is well evaluated, well treated using let's say a psychostimulant medication, educational support. The kids are getting behavioral support as well, and then they develop an episode of depression. So the depression looks like regular depression, as you would if you didn't have ADHD, but it's a complex situation because the kids have an underlying ADHD. They're often on medication. In general, I would say that for the purpose of those kids who are on the mild to moderate end of the spectrum of depression with well-controlled ADHD, you could probably follow the MCPAP clinical algorithm for depression without too much trouble. You do have to be aware that you're getting into more complicated psychopharmacology when you're adding an SSRI to a stimulant medication, but in general, it's safe, it's generally appropriate. In that situation, I think you could reasonably follow the MCPAP depression algorithm with a kid with well-treated state ADHD. If ADHD is out of control and you've got two active problems, and that to me gets into a level of complexity that probably would warrant at least a phone consultation, if not an in-person consultation, if not referral to specialized care. So I think there are situations where you certainly could follow the MCPAP depression algorithm, in situations where the comorbidity is not well treated or out of control, not well evaluated, and I think we're talking about at least consultation, if not more specialized care.
Thanks. All right. Another question is, have you seen situations, and what do you do if the PSC by the youth is different than one that's filled out by the parent?
Well, we see that all the time. I think we see, different sources of information often conflict, and it's to me, it's like a dream when, if you're getting a rating scale from a parent and the child, and they're, they completely support each other. And similarly, like this is outside the range of the topic, but the agency, when you get a rating from a teacher and a parent, which are very much in agreement. So I've tended to to say is that if you're collecting information from two sources and they disagree, then you have to put it together somehow. You have to come up with an understanding of that. In situations, the kid may not be a reliable or valid reporter because they don't want to admit what's going on, or they're in denial of different symptoms. In certain situations, parents could be unreliable reporters because they've minimized stuff, or they're not really closely in touch with what's going on with the kids. And that tends to be the case to some extent with internalizing symptoms. So parents may not be aware that a kid is suffering severe depression, attributed either to like laziness or behavioral issues or things like that. And other situations where both are giving their valid assessment of what's going on, and you've got to put it together somehow. And there's no easy algorithm on that. But what I generally say is start from a place where you think both reporters are valid, and then try to do a further assessment to give a really good explanation in your own mind of why there's such a discrepancy in the ratings. And at times you're going to have to make a clinical decision. I think the kid is reporting valid symptoms of depression the parent is not aware of, and I think this kid's got depression. And you may just have to formulate it that way. And it's not to criticize or point fingers at anybody or to make anybody feel bad that they weren't aware of what was going on. It's just you have to make sense of the story, and you have to put the different sources of information together in a way that you can understand it and move forward with treatment recommendations.
Thanks. So that's all the questions we have at the moment. We have a few more minutes. Bruce, any other thoughts about maybe a situation that's come up?
Well, one of the things that we struggled a bit with when we were thinking about the algorithms is, I'm aware of this from my work with TADS and other things, is that there are evidence-supported types of psychotherapy for kids with depression, especially for teenagers. So we're aware of in that study, we used something called cognitive behavior therapy. I'm also aware of an evidence-supported psychotherapy called interpersonal therapy. And we decided to not put the evidence-supported psychotherapies in the algorithm per se, because we know that it's hard enough to access general psychotherapy, and it's very hard to access these evidence-supported because they're often only available at specialized centers or with selected practitioners. So we've made general recommendations about psychotherapy, and we do feel that there's evidence suggesting that a variety of different types of psychotherapy, such as supportive therapy and psychodynamics psychotherapy, can have very positive effects on depression for kids. So, you know, in some ways, as a purist, I would really prefer that we could kind of get more evidence-supported psychotherapies, like evidence-supported medications for kids with depression. Practicality is that getting psychotherapy in general is important as a treatment component, and the evidence-based psychotherapies are an additional positive if you have access to them in your communities. I do think that if we pushed as a group, trying to get our psychotherapists in the communities trained in some of the evidence-based, evidence-supported therapies, it would really be a good initiative. But we did not move forward with evidence-supported psychotherapy specifically singled out in the algorithms for those reasons.
Larry, are you still on there? Do you have any other thoughts? All right. Well, it's a little early, but I'd like to thank Bruce for one presentation, and encourage all of you to site and encourage other members of your practices or your friends to listen to the presentation, so that we'll all be on the same page when these kids are being seen in our practices. Okay.
I'm unmuted now, and I'll just add that you know, this is the first version of our clinical practice guidelines set, and we're really looking forward to getting feedback from people. So if you download it from the web once it gets posted and begin using it, we'd love to hear any feedback you have, and we can always continue to iterate versions of this to make it more useful for people. And thank you, Bruce. It was fantastic.
Just a reminder that at the end, when you close the webinar application, you'll get a survey, and we appreciate having your feedback. And reminder that we will again have another clinical conversation on the 4th Tuesday in February, and tentatively that's going to be on anxiety, and which is our next will be the next algorithm we'll be rolling out. Thank you, everyone, and have a great day. Bye now.
Bye-bye.